Next case, this patient had multiple areas of occlusion, SFA, popliteal, distal PT. And you can see, unfortunately, pretty extensive tissue loss. Unfortunately, when you have an ulcer in the heel, so the image on the left is actually the patient's heel. We are looking at it from below. Gangrene in the heel is very difficult to get to completely heal because they tend to put most of their weight on it. So I tend to treat everything all the way to the heel. If it's just like Karthikeshwar, we they have tibial disease, we would treat the SFA, and most of the times that's enough. But when you have this much tissue loss, we like to go, you typically want a palpable pedal pulse if possible. And you can see this patient has a high-grade SFA lesion. Again, the one lesion here is almost occlusive. So again, I would like to avoid getting in a subintimal plane. So that's where I think the javelin catheter is very useful. Typically, we'll set the wire there, start pulsing with the javelin so we get right through the true lumen. You can see another high-grade stenosis in the popliteal. So very tight SFA, very tight popliteal. Looks like I'm showing you some IVUS images. Like this would be after I crossed it. You can see dense wall calcification there. So here again, I've crossed the lesion. You can see the javelin catheter is now all the way in the above knee popliteal. And I use the same technique. I don't have a cine on here. These are all fixed images, but I would typically sit my wire above the lesion. If it goes right through, I would follow the javelin. Again, this patient, we had a difficult time with crossing it with an 014 wire. So I park the javelin catheter right above that, start pulsing. Once I get through it, we'll kind of take the same catheter to the next lesion. So this is, the pre is on the left side. You can see the super tight lesion. Again, with just crossing with the javelin, we have some luminal gain, probably about 30%. I also use that since I have the wire across in the popliteal lesion. So again, you can see there's a reasonable luminal gain. Again, I think for larger vessels like the SFA, you do have to follow with another Shockwave balloon, but for tibials, it tends to work as a standalone. I don't think you need to go back with a larger Shockwave balloon. So I did an intravascular ultrasound. I showed you the images before. Again, I sized pretty accurately intima to intima. I've used a 6 millimeter E8 balloon, treated both the popliteal and the SFA, followed with a DCB. You can see it looks very good. That's just a branch. That's not a dissection. So it looks beautiful, nice flow, no flow limitations. So I'm not going to do anything further there. So here it's a pretty nice looking anterior tibial, but remember this patient has a huge ulcer right here on the heel. She does have some toe ulcers, so I think that will certainly help because we have fixed the SFA. AT looks pretty good. Some narrowing there, but my biggest concern is that she has we call this an incomplete plantar arch. You can see even though the AT is filling very well, it doesn't heal the area. It doesn't fill the area on the heel. So I'm going to see where I can get through that, maybe try to fix that. So that's the reason I want to do that is because of the ulcer on the heel. So here again, I'm showing my javelin catheter. You can see that I have the wire all the way across the plantar arch. I'm kind of following with the javelin catheter, trying to open up that one area that was occluded. And this is just with the javelin catheter. You can see on the smaller vessels, you have a very nice, so that's a normal vessel higher up. Again, it's not as robust as the AT, but you do want to increase as much flow as possible. And you can see even just with the javelin, we have a pretty reasonable luminal gain, and now we have a complete plantar arch. I follow that with not sure, maybe a 2.5 balloon here. And you can see our completion angiogram looks certainly a lot better. So in this patient, we use the javelin to get through 99% stenosis in the SFA, a popliteal lesion, a CTO of the distal posterior tibial, and we did debris her heel. She has a wound vac on. It's continued to granulate very well. Hopefully it will continue to heal.